What image comes to your mind when you think of a psychiatrist? For me, it's a guy in a plaid blazer sitting in a comfortable chair, legs crossed with a legal pad on his lap. He's got thick-rimmed glasses, and the office scent is an amalgamation of cigar, musty books, and potpourri. Also, the year is somewhere between 1930 and 1960, and he's sitting next to a bookshelf and, of course, a Chase lounge. When I think about this caricature, I don't think of him as someone who practices medicine in the traditional sense. I think of someone who practices some sort of psychotherapy. But what does that even mean? What does it look like? I know psychiatrists are medical doctors, at least that's my own personal life plan, but I could almost count on one hand the number of facts that I learned about psychotherapy in medical school, and I think that's par for the course. But then we are thrust into residency, slapped with the department label of psychiatry, and we intrinsically understand that the role we're taking on is going to move past the medicine we learned for step one and into a more humanistic direction. We know that as psychiatrists, we're going to be venturing into the realm of psychology, ethics, and existentialism. We're talking to people about sadness and mania and suicide. In a broad sense, we enter into the realm of spirituality. We discuss a patient's meaning in life and their sense of belonging in the world and what they feel their purpose is. We also understand from medical school that psychotherapy is the treatment of choice for certain patients, but the curtain doesn't get pulled back very far when going over the explanation to the multiple choice question where you chose DBT for a patient who is meeting criteria for borderline personality disorder. So the goal of this episode is just to serve as a primer and to whet your appetite in terms of psychotherapy training. It can feel daunting, and depending on your career goals, you may be at a point where you're not even sure how relevant it'll be, given that modern corporate American medicine has wedged many psychiatrists into a role that approaches near medication management. Dr. Sudak is one of the world's top experts on this topic. She was the first person that came to my mind, and I'm humbled and thrilled that she generously agreed to join us. She initially came across my radar as the chairperson for the Psychotherapy Committee for the professional organization that all of our program directors belong to. So I'll say she was the person in charge of teaching the teachers how to teach psychotherapy. Without further ado, welcome to the podcast, Dr. Donna Sudak, and I will ask you to introduce yourself.
Sure. So I'm Donna Sudak. I hail from Philadelphia. I've been a psychiatrist and a psychotherapist and went into psychiatry to do psychotherapy, actually, for a number of years, but primarily I worked in psychiatric education for most of my career, at least over the last 25 years or so. I'm a program director at Tower Health Phoenixville, and I've been program director in that particular program for its previous incarnation since about 1995. My interest in psychotherapy has really been in CBT and other types of evidence-supported psychotherapies, and also about how to keep it as a part of the training of psychiatrists. And so that's really my professional background. I've also been involved with the APA, used to have a psychotherapy committee and then became a psychotherapy caucus. I've been president of the Academy of CBT, and I also teach at the Rec Institutes.
Well, thank you for fighting the good fight. I think it sounds like you're fighting to keep our profession sort of pure and true to its values. So I think this is one of the most broad topics imaginable when teaching psychiatry residents, and we're going to try to tackle it in less than 2 hours. So what we're not going to do is try to cram 4 years of residency in it, but just pique people's interest a bit. Do you think that spending even just 1 to 2 hours of deliberate time learning about these principles can make a concrete difference in how a psychiatry intern might treat their patients?
Oh, absolutely. And I think that the most important thing to remember is that every single encounter in psychiatry employs the tools of psychotherapy. And if it doesn't, one of the things we know about is that it doesn't go so well. There have been some really lovely studies about that have been conducted in psychotherapy and medication head-to-head trials, where one of the things they want to do is to make sure that they don't contaminate medication management with any psychotherapy principles. And they had one person in one of these trials, this is a trial about anxiety disorders, who got the worst outcomes imaginable with medication management. And when they looked at what this person was doing, what they were doing essentially was to a psychotherapy-free prescription management program. And they got 10% to 20% response rates using imipramine for anxiety, which is much lower than one would expect. I think basically because people didn't take the medication. So that we need these principles. I would posit that it would be good for all physicians to understand some of the relational aspects of psychotherapy in order to take care of patients.
I love that. Sometimes I'll ask a patient if they've been to psychotherapy in the past, and they'll say something like, well, I've been to therapy, but I don't know about psychotherapy. Or oftentimes people will say, I went to a counselor through school. Is that what you mean? So I guess my question for you is that what I mean? What is the difference between therapy and counseling, if at all?
Well, so counseling can be therapy, depends on who's delivering it and what the principles are behind it. What we do is really different among therapists based on how we think about how problems happen and what we've been taught to do about them. And I've seen people, the take that I have about it is that often I see people who come into our clinic and they say, I've been to therapy and it doesn't work for me. And when you ask them what actually happened is they went to see someone once every 3 months and got medicine and also talked with them during once every 3 months, which may not constitute therapy for most people. So the idea is having, I think, a principle-driven, goal-focused way of helping somebody to learn something new in the context of a relationship. And that underpinning informs psychotherapy, it seems to me.
What types of problems can psychotherapy be helpful with?
Well, so this is a curious question. I think that one thing that's quite important from my point of view is that we should think about psychotherapy the way we think about medication. I think we, as psychiatrists, ought to, when we see a patient, make a good diagnosis and then make a decision based on what the literature tells us about what to use in that diagnosis. What does the literature say about patients with a depression, for example, or with bipolar disorder? What kinds of treatments and in what combination make the most sense? And I would say that in many of the problems that we see, there's a limit to the research, particularly with respect to personality disorders. And we could talk for hours about the reason that doesn't exist. So first off, I think we ought to look at what science tells us. But we also know that psychotherapy helps people change the habits of thinking that they have, what I call the Achilles heel of the mind. Those things that get us into trouble repeatedly might not connote a major disorder as we think about it, but sure can make life miserable. And we can help people change those with therapy. We can help people give authority. The way I talk about it, it's giving your prefrontal cortex authority over the rat brain, because the rat brain generally wins if it's screaming loud enough. And you can help people learn to modulate emotion more effectively. And the other thing that happens is that early learning that's painful is persistent and sticky and often can cause us lots of troubles. And so we can help people with the relational aspects of therapy and these principles to unlearn some of the early learning that happened before they were capable of thinking of things in different ways. Last but not least, we can help people cope better with major life stressors, including life's vicissitudes in terms of genetic vulnerability. And by that, I mean that there are some people who are genetically vulnerable to particular illnesses, and we can help them not only cope with the illness and do better with that, but also live like a well person with a psychiatric illness.
So I'm hearing that the application is really broad in terms of what it can help with, but what's important is knowing what your goals are, knowing what, you say your diagnosis, certainly the full formulation that's going to be helpful for you, and then matching that appropriately to what we have evidence for that works.
Yes, absolutely.
What brings a person to psychotherapy typically?
Oh, gosh. Generally, either a significant psychiatric disorder like anxiety disorders, depression, bipolar disorder, but usually it's the problems in living that problem causes. There's a real difference between making a diagnosis and making a problem list. So it's frequently the case that a resident will come in and I'll say, what's wrong with the patient? They'll say the patient has major depression. And I'll say, well, what are the problems of the patient? And they'll say the patient has major depression. And generally speaking, that's not what a patient will tell you. They'll tell you that they're not getting out of bed and they're crying all the time and they've gotten fired from their job and they're not opening their mail and they're not paying their bills, et cetera, et cetera. So the things that bring people to therapy are generally problems in executing life functions like work and taking care of yourself or navigating bad problems in relationships.
One thing that's been difficult for me personally, ethically, professionally, clinically is, suddenly I became resident and now I have a prescription pad. And, I was trained in medicine, and in medicine, we make diagnoses and then we make interventions based on those diagnoses. And I think one of the most obvious interventions is prescribing a medication. But I know from my personal experience and from my values that I don't think that's always best for every patient that is sitting in front of me. This can be really difficult to balance in my clinical decision making. So how would you suggest that we balance the role of psychotherapy and medications? Like, how do I determine if I can choose psychotherapy alone for a patient? What factors am I really considering?
So this is what is commonly known in my parlance as I've got a prescription pad and I'm not afraid to use it. But science is what should tell us. I mean, we should be looking at the literature. There is data about this. So for example, we know that if you treat somebody with panic disorder with CBT and medication, it will work as well as treating them with CBT alone or medication alone, and probably work faster. But if you treat them with both, what's interesting is that if you stop the medication and stop the CBT at the same time, it's not as durable as CBT alone. And so the questions you have to ask yourself is, and in working with patients, the way I think about it is from informed consent, is who is the person in front of me? What immediate dangers are there if they don't get better sleep, if they're not able to process information? And what's the long-term durability of any of these interventions, either prescribing and doing therapy together or doing either one alone? Generally speaking, from the standpoint of psychotherapy, CBT, if you respond to it by itself, is a much more durable intervention than medication, for example. But for some people, particularly if you have a high pressure job and you're not sleeping and you're highly depressed, you may decide that you need to have an intervention that will help you be able to function better in the short term. And then, generally speaking, there are lots of wonderful rubrics about how to navigate stopping medication and continuing therapy for a short period of time that extend durability wonderfully. And this is available to us. And it's just a question of watching what the science really tells us.
So therapy has a very long half-life, is what I'm hearing. We're talking a 6-month half-life on good psychotherapy.
Actually, we're talking years. You can extend the durability of recovery from depression for 5 to 10 years in many series. And in fact, in Europe, the standard of care is to get medication and in many countries with the National Health Service, have 8 to 10 hours of group CBT after you withdraw the medication and the person has responded in order to extend recovery.
Wow, such a powerful tool. So I often tell my patients that the best ability for any therapist to have these days, at least here in Omaha, is availability. It's not really as simple as a couple of clicks, maybe a referral. Tomorrow the patient has an intake. It can feel impossible to get my patients in with any therapist, especially if I have a certain type of therapy in mind. So kind of given the nature of the psychiatric landscape as it stands, where do you think psychotherapy fits into psychiatric practice?
Well, for someone like me, it fits in my everyday. That's what I do. And that's what I have done for my entire career, besides teaching people. And I think that it is true that there are fewer psychiatrists who are hired to positions that allow this to happen. I will say that I think that the landscape about this is changing, that in fact, as COVID made it possible for people to have private practices in their living room, they got less scared about doing that. So the number of psychiatrists doing therapy right now in Philadelphia is much larger than it used to be. And I think that, psychiatry is the most popular specialty at this moment in terms of the ratio of applicants to acceptance. And I think that, at least in my landscape, lots and lots of people who want to do it because they want to have relationships with patients. They want to be able to talk to their patients and know who they are and do something therapeutic besides just write a prescription. And because there are fewer of us, I think that people will be asking for more ability to combine this as an intervention. Now, this doesn't necessarily have to be in the 45-minute hour landscape. There are many people, myself included, who see lots of people in 20-minute sessions, people who have been established patients for periods of time and learned the tools and who are on long-term medication. And there are lots of ways of augmenting the hour that you spend with patients, both technologically speaking, and also in terms of varying the amount of time in which you see a patient. So, for example, if you look at the UK, where psychotherapy actually is the standard of care in addition to medications for a number of different disorders, what they do is they stratify who gets what intervention based on severity. So if you're mildly depressed, you'll get a guided self-help book and multiple phone sessions. And if that doesn't do the trick, then you're going to be seeing a psychotherapist. And if you have a treatment-resistant depression, you're going to be seeing a psychiatrist who also has the time available to do therapy with you. And so we can, there are other models for thinking about this than you're going to see the same person 5 days a week.
Yeah, so psychiatric diagnoses are not a monolith. And I'm hearing that depending on the whole formulation, a different approach might be necessary. One thing that I hear a lot from patients when I am sort of talking about, would you like to start psychotherapy? How has it gone in the past? They'll say something like, well, I don't see how just sitting down with somebody and talking about my problems is going to help me feel any differently. Or sometimes I get, well, yeah, I mean, I do psychotherapy. It happens around my dinner table. That's what friends are for. I talk to friends about it. Do we know how, in a clinical sense, psychotherapy works?
So we know that psychotherapy changes brains, that's for sure. And there are lots of studies that show the neurobiology of this. What is really the case is that coming in to talk about your problems is not what therapy is about. Psychotherapy is work, and it's working to change things about the way that you approach something or about the way you think about something. And so I think that it's important that people understand that there's more to this than just ventilating in the same way that you would to a friend. And I think, of what the beginnings of therapy is about is really acculturating people to that. Psychotherapy is fundamentally about being in a relationship with someone who behaves in a certain way that makes the world safer for you. And that would allow you to be able to learn something new. And almost all therapies involve exposure to something, to some intense emotional state that frightens you or saddens you, or some ideas that you have about yourself or about other people that need to be revisited, generally in the presence of emotion, and that allow you to learn something new about that based on being an adult, based on having a different perspective. And often it's the case that the relationship itself motivates people to have the courage to try new things. We think about, or I think about, and certainly other people smarter than me think about, the fact that the relationship between you and the patient is probably the single most important thing that gets people the courage to hang in there, to stick it out, to try new things. And I would say that one of the most moving aspects of being a therapist is seeing people have the courage to try things that really make a difference and change their life. My patients have been some of the bravest people I've ever seen. And it's extraordinary to be a part of that space. It really makes going to work every day a gift.
The bravest and certainly the best teachers. I'm really glad you went there, because I think that the people listening to this podcast who are about to go into residency or about to go into practice have a lot to look forward to. It's a really special, sacred, rewarding career that you've chosen. And you really get to know people in a very intimate way. And I think connect yourself more deeply to the human community. So when I talk to med students about psychotherapy, because this is how I felt when I was a med student, I will use the phrase alphabet soup. So, we have DBT, ACT, CBT, and for an M4 headed into intern year, it can be kind of a head-spinning number of acronyms to keep straight. And to be honest, I think usually what we're doing is we're just taking a acronym and mapping it to an associated diagnosis to get a question right on the shelf exam. Can you help me now in a more practical sense to make sense of this alphabet soup? How can we organize these different acronyms, these different types of therapies into our brains?
So actually, probably the thing that is the most enduring thing that I've ever been grateful to be a part of is writing about this in a way to try to make sense of it. And the psychotherapy committee of the APA, which when I was on it was headed by Eric Flake and David Goldberg and some other folks were on that committee. We kind of looked at what the literature said. What did the science say? What distinguished this alphabet soup? And at the time we were doing this, there weren't as many alphabet letters. But that the whole idea of this comes from a tree trunk. Almost all therapies have a tree trunk. And we call this the Y model. And that tree trunk really involves common factors, the kinds of supportive and humanistic interventions that help you form a relationship with someone that is psychotherapeutic, not friendship. And all therapies, good ones, share these, all evidence-based and otherwise. And then the therapies branch into really two different types, it seems to us. One is the more directed therapies, like CBT, DBT, ACT. And most of these are therapies that not only are more directive, but they are also therapies that have empirical support. They were designed after a time when what CBT did that was quite different from other types of therapy is that Tim Beck was interested in the science behind this and wanted to actually research how did this size up compared to medication, compared to other types of therapy. And so it was really the first of the therapies to have empirical support, and now is one of the most investigated things in all of medicine. But these therapies are much more directive. They often involve goal setting and exercises where the therapist is actually actively teaching the patient particular skill sets, and as well often have a component of measurement week to week in terms of how the patient is doing and making sure that one is tackling those particular goals and diagnoses in an effective way. And then there are the evocative therapies, and the most obvious example of this is psychodynamic psychotherapy, where the whole idea is exploring the emotional aspects of relationships generally, and that the evocative piece of this is the therapist's endeavor to both help the person to discuss and experience emotion in the session about particular things that go on, but also to use the therapeutic relationship as a paradigm for other relationships and explore the emotions that are evoked within that. There is also emotion-focused therapy, that's Les Greenberg's work, where the focus is on really exploring problematic emotions that one has and ideas about that within a session. And sometimes that's done in chair work as well as in discussing relational things that go on day to day. And there are some of these that now have begun to develop an empirical support as well, but certainly not to the degree to which the more directive therapies have. They've got, many years that they've been investing in that kind of investigative work. But so you can see that distinguishes the two. And the activity of the therapist and the use of the relationship with the therapist is somewhat different with each of these branches of the tree.
So in our why model, we sort of have at the top of the why on one side, more directive approaches. These are often manualized therapies. And then on the other side, we have more evocative therapies, things like psychodynamic psychotherapy.
I think what's really important is that, as you mentioned, the manualized therapies, we don't use manuals even in directive therapy. We use manuals to test out therapies. That's what the manuals are for, is to make sure that we're actually doing the intervention that we're testing. And so the tradition of using therapy manuals came from wanting to study them scientifically. But they are also therapies that were studied in very, very well-selected patients who never come into my office. It's very rare that I see someone who has a new onset of a major depression, no other diagnoses, no other complicating factors, no personality issues, and just had the, genetic good fortune to have that, and then waltzes into my office. And I can say to myself, this isn't going to take very long, most likely, and it's pretty lockstep to know what to do. Generally, we write the manual, and you write the manual because you have someone with multiple diagnoses, and you use a conceptual framework to make a decision about what to do first, second, third, how you're going to, I say to my residents, patients are a lot like Google Maps. Road conditions tend to change. From week to week, you might have a plan, but it may not turn out that way. And the reason to know the manual is so that you can be flexible in the application in real people. But that's different from saying, this week I'm doing CBT and next week I'm working with dynamic therapy. It is the case that at the end of it all, the most experienced therapists tend to work similar. I used to joke about this. My husband's an analyst, and imagine what dinner is like in our house. and so I used to say, we used to have an office that we shared, that if you had a hidden camera in my office and a hidden camera in his office, and he was seeing a really depressed person, he might say to this person, I'm wondering what you could do this weekend that might be enjoyable for you. And you could have the same hidden camera in my office, and I'd be saying to the depressed person I was seeing, I'm wondering where you learned in your childhood to think about yourself in this way. And you wouldn't necessarily know which one of us was which until you looked at the whole session, because we're dealing with human beings. And, splitting and all or nothing thinking look very similar because we're describing humans. We just have different terminology for that. But the way that I think problems develop and the way that Howard, my husband, thinks that problems develop are somewhat different. And how directive I'll be in suggesting assignments, in asking people to do things, in setting agendas, in setting up what we're going to talk about through a session and work on is going to be different than how he does things. And the approach that he takes to the way the patient thinks and feels about him is going to be different than what I do. So I don't know if that explains things a little bit based on your question, but that's sort of how I think about it.
Yeah, that parses things perfectly. That sheds a lot of light for me, and I'm sure for our listeners. Psychiatry Boot Camp is brought to you by Simple Practice. Are you thinking about starting your own practice, but you're too daunted by the business and logistics? Or maybe you have a practice, but you're spending so much time on scheduling, record keeping, and billing that it's burning you out and slowing you down? Simple Practice is the solution for you. Simple Practice is an all-in-one EHR designed to help practitioners thrive. From admin work to clinical care, Simple Practice has a suite of tools that work together to simplify practice management. This includes e-prescribing and PDMP checks integrated within the app, and a lab slip template that can be easily sent to patients within the portal. With Simple Practice, you can spend your time on what matters most. For an exclusive 7-day free trial and 70% off 4 months, visit simplepractice.com/bootcamp. That's simplepractice.com/bootcamp. Psychiatry Boot Camp is brought to you by Beat the Boards. I am so excited to have Beat the Boards as a partner because this is the question bank that I used to study for my own psychiatry board exam, and it made the exam a breeze. The Beat the Boards question style was so close to the style of questions on the real exam that I felt over-prepared during the test. Beat the Boards has courses in psychiatry and virtually every other area of medicine. Visit beattheboards.com to view the entire catalog and take advantage of Psychiatry Boot Camp's exclusive additional 10% savings by entering the word Boot Camp in the referral line in the shopping cart. Again, unlock these additional savings with referral code BOOTCAMP. That's one word, no spaces, Boot Camp. One of the ideas that I do find really comforting as a resident and as someone who feared drowning in the alphabet soup is this concept of common factors that you've been talking about. I think common factors are sort of the life raft for a fourth-year medical student, PGY1, who feels a little bit overwhelmed by all of these different types of psychotherapy. I've seen the number cited in the literature as high as 80% in terms of the proportion of an outcome based on common factors versus any modality-specific factors. What are the common factors? Could you kind of go into those common factors that lead to positive outcomes regardless of the type of psychotherapy?
I will do so, but I'm going to talk about what you just said first because it's my particular bugbear in many ways. So if we look at the common factors and say 80% of the outcomes are due to the common factors, that's like saying antibiotics work. But if I have a gram-negative septicemia and you give me ampicillin, I'm going to die. And if I have OCD and you treat me with the common factors, I am not going to recover regardless of how lovely our relationship is, how much you accept me, et cetera, et cetera. So the common factors are necessary but not sufficient. And it depends on the diagnosis. If you look at certain diagnoses like depression, common factors are very, very helpful. There's no question about it. They can, for some people, be enough, not all, and maybe not as durable. But the fact of the matter is that we need to, when we're looking at common factors research, we need to separate out diagnoses to know just how important the common factors can be. However, if I want to do exposure and response prevention for my OCD patient, and I don't have a decent relationship, I might as well be talking to myself. So the common factors are the life raft and the hull of the ship. I'm not going to get any place without them. I can make the most beautiful interventions in DBT whatsoever, that I could, but unless I have a good relationship with the patient, we're not getting anywhere. So that's the first piece. Common factors really are, number one, who are you and why should I trust you? Is making this person feel safe and accepted. The second thing is, why should I believe that any of this is going to make a difference to me? And one of the things I think we forget is just how demoralizing having some of these problems can be. That many times people, certainly by the time they see a psychiatrist, one of the things I think it's important for the residents who are listening to this to appreciate is that we see the most challenging patients. The people who get better easily are not coming to us. They're going to get treated in family medicine. They're going to respond to the SSRI, say thank you, and be on their way. And I was well into my private practice before I ever saw anybody who did that, because we see the people that don't respond to that. And we should. We have the most training. We ought to be practicing at the top of our license. But then what it means is that by the time this person gets to us, they have already cycled through a lot of treatments and been through just a lot of crap. They feel terrible. And so we have to impart a sense of hope. Why is it that this is going to be different? We have to develop, as part of the common factors, a shared language and a shared understanding of what the problem is. If the patient thinks that the problem is one thing, and I think that the problem is something else, it's a non-starter. And that is often a big piece of the engagement in psychotherapy, because the patient generally comes in and says, this hurts, I'm in a lot of pain, and I'm distilling out all this information, and I'm thinking, well, this is a person who needs to be less controlling in their relationships, and this is a person who needs to have better understanding of what procrastination is doing in their life. And so I've got all of this laundry list of things that I'm coming in with and thinking, this is all the stuff that needs to be different. But the patient is like, ouch, this is terrible, and my life is terrible, and fix that. And so we need to develop a shared understanding of how did things get like this, and then a shared understanding of the pathway out. And what are the goals? How achievable are those? And this is the Goldilocks moment in therapy. This is where you have to make a decision about making it just the right size so the patient is, reaching for something, but it's not too far, and feels a sense of accomplishment and relief. Oh man, I can do this, in order to take the next step. It's the My Last Duchess moment, if you know that poem. The other piece about it is we're humans. We need to be humans together in this. We need to feel what it's like to be in this person's shoes. We don't need to necessarily have those experiences, but we need to understand the deep meaning of the experience to the patient and why it is that way. And so empathy, being genuine, being like a for real person, having a sense of positive regard for this human across from you. When I first went into residency, I think I'm trying to remember when I asked this question to somebody, it was, do you like all of your patients? And the answer that I have in my mind now, many years later, is yes, eventually I do. That it's, in the very beginning, sometimes it's kind of like, okay, but generally speaking, sooner or later, there's somebody in there that you get to know and care about in a way that is really important, I think, as a part of the recovery. Being able to be compassionate, having a sense of respect, and I think being optimistic really helps. I know that being a person who believes that things are possible for someone. And last but not least, I think that part of the common factors is having a sense of humility and having a sense of that you are not going to know what it's like to walk in every person's shoes, and having the guts to say that to your patient in a way that allows them to make a window for you. Saying to someone, I may not share the same experiences as you. I'm a middle-aged white lady, and so I hope that if there's a time where I really am missing the boat, you'll be willing to let me know so that I can understand things. So I think that's a piece of the common factors, and certainly one which I think did not get sufficient play, certainly when I was a resident.
And I really appreciate your point about how, sort of what you're implying is that a lot of these things get easier as you have more experience. And humility for me is a big one. Every year that I go in residency, I think I am objectively more competent, at least the Pride says so, but I feel like I know less and less of the human condition because my eyes are being opened to more things that I had never considered in my own life. And so I think that's why it's so important that our training is sort of so long, because there are so many facets to the human experience that we have to be aware of when we're talking about changing the way people exist in the world. So I think that humility, certainly, I feel that coming on really strongly as I kind of move toward my later years of residency. The other thing that I want to flag is you mentioned this positive regard and do you like the patient? And I think it can be a useful exercise if you are feeling that you do not like a patient, you're having that sort of negative countertransference, to talk about in supervision, what is it that I don't like about this person? And sometimes in kind of bouncing those ideas around with trusted colleagues, you can come to a better understanding of why the person is the way they are and maybe understand them better and ultimately possibly even, like them better, which can lead to better outcomes.
Well, I really like that idea. And I also think that it's important that we recognize that sometimes we have ideas about how patients should be, how they should act toward us, and that can interfere with things as well. So that, and those ideas may or may not make sense, right? And so it's important that we know that. And I think this is a very important point. And I watch residents over the years approach the end of their fourth year and start to become incredibly anxious. Yeah. And I'm always very happy about that, because we graduate you as competent. We don't graduate you as Jedi Masters. We don't have the time for that. And you probably don't need to be a Jedi Master. But hopefully you know that you want to do that. And, I tell people that I think it was 4 years after I was done residency where something didn't surprise me every week. That there are just a lot of things that are going to happen along the way that you aren't ready for, either because of your own situation as a person, because you are going to be a human as well as be a psychiatrist. And so things are going to happen in your own life that you have to juggle with this job, or the things that happen with patients. And so having a group of people to bounce those things off her, having a reflective framework to navigate this through is really, really critical in terms of your own progress, your own mental health, your own ability to do this. And one of the things that's amazing to me is that psychiatrists work longer than any other profession. And it's not just because of debt. I'm just going to tell you, I know you guys think it's like because you're going to be paying it off forever, but that is not true. But it's because it's endlessly interesting and rewarding, and because you really do get better. I am a much better psychotherapist today than I was when I left residency. However, it's also because I practice. We know that people's skills deteriorate in every profession, in radiology, in psychiatry, in every profession. There is drift, and we know that people who don't deliberately practice what they're doing, listen to their work, rate their work with instruments, have colleagues that they discuss things with, think about their patients, actively pursue learning new things, we know that your skills are going to deteriorate. And quite frankly, I don't want, my mother, God rest her soul, if she was still with us, but I don't want my family member to see somebody who isn't continuing to improve their skills.
Yes, this job is rewarding, it sounds like, but it will change you. And that can be one of the joys of the job. And one of the benefits of this job is that it will change not only your work skills and your professional life, but also who you are as a human being. So let's talk a little bit about sort of this big common factor, empathy. How would you define empathy for us?
Empathy is feeling with someone. That's how I would define it. Most people that in their very start hear something terribly difficult that's going on in someone's life, and they'll say, I'm just so sorry that that's happening to you. And that's a perfectly appropriate thing to say, but that is sympathy. That is not empathy. Empathy is being able, either because you affectively resonate with that person and you can see and feel their experience, or because you know the person well enough that you cognitively resonate, or you take a step out on a limb and say, oh, I can see that you're so sad about that. It's speaking to the emotional state in a way that resonates with that person's emotional state. And I'm here with you is the other piece. And there are a number of wonderful YouTube clips about this, usefulness of it. There's a Brene Brown clip on YouTube. But if you know the movie Inside Out, there's an amazing clip about empathy where the sad character speaks to the toy that is about to be sort of out of the little girl's life. And you can see how that empathy can move the person from being stuck to considering other options. So that we express empathy by both expressing our thoughts about the person's perspective. We resonate emotionally with that person. We can communicate in both verbal and nonverbal ways. That we hear and experience the feeling state that the person is having. And when we want to convey to the person that we really care about them. We really care about this that's going on. And that skill is, I think, a critical one to develop. But it often winds up the case that people are worried about going out on a limb because they don't want to name the emotion, get it wrong. And generally, you can extrapolate by being a human and knowing, for example, that the death of another person usually connotes that you're sad about it, but sometimes that could be incorrect. And if you are, you find a way to sort of say, oh, gosh, I'm sorry I got that wrong. And I'm really glad to know. Thank you for telling me that it wasn't like that for you. And that's one of the other things that you were talking about being a beginning therapist that you don't know about, which is that you don't have to be right all the time. You have to model being a good human if you're not correct in your perceptions. And you need to be a little careful and try to understand this human who's with you and what's important to them. And then you can empathically resonate, generally speaking. But if you get it wrong, you could say, oh, gosh, I really missed that. And I didn't know that about you. Thanks for letting me know. So I think that it's easier to say, I'm so sorry this happened to you. That's quite different than saying, I see how much pain you're in that this occurred.
Even just listening to you talk about it, I can feel sort of my body changing. And what I'm thinking about is just how this is such hard work. Day to day, this can be really draining. It's a really emotional labor. And I personally think that that's one of the things that sets psychiatry apart in terms of the work that we do. In most psychiatry residencies, we are probably pulling fewer all-nighters than in some other medical specialty residencies. But this is a really unique type of work. And I know that for me in my intern year, if I didn't have some time after going to the inpatient unit and talking to suicidal patients all day, if I didn't have some time after work to sort of process that and some healthy strategies for managing that, it really started to wear on me. So I would really encourage our listeners to be aware of that because, what you're listening to can be really difficult at times. So we want to show empathy to our patients, but how can we really know what our patient is feeling?
Well, you can certainly ask them, right? So like, Where did you feel that in your body? What was that like? And you might name a feeling. I imagine it might be like this. You can ask them what they're thinking. What was going through your mind at that time? You can ask them, are you feeling something right now? And do you know what you're feeling? Can you name it? Sometimes people have a much more difficult time than others being able to do that. It's a skill that you learn if you've got good parents, generally speaking. But sometimes people aren't very good at it. Part of what we do in therapy is to teach them how to do that. And just naming an emotion gets it to start to regulate, which is really, really important. And part of this is just listening. One of the toughest parts of being a resident, frankly, is that you haven't developed what I call the 8-track therapy mind. And for those of us who are old enough and remember 8-track tapes, there are tapes that were actually recorded on different tracks and they blended the music together and it sounded really good and they were big and clunky, and now we don't even have tapes at all. But the idea is that you're trying to do so many things when you're a resident. You're trying to do so many different things. You're trying to, remember the story, and you're thinking about what are you supposed to do next, and what question am I going to ask, and oh no, it's CBT. I've got to be able to do a thought record. Should I do a thought record now? Is now the time? And so all of that is occupying space. And so frequently it's hard to remember that your best job to start out with is just listening, getting the person to tell the story and hearing the music and not just the words. And so, I think about this empathy business as that's hearing the music. And that it's important to be listening to that. So some of the things that you learn as a resident have to get to be automatic. That's why assessment and the questions that you have to ask about each diagnostic category has to be automatic. It has to be something that you would do without thinking. And the order of operations in terms of your interview has to be something that would be automatic. And honestly, in the first and second year of residency, you get to be the best question asker in the world. And you ought to be, but it ought to be on autopilot so that when you are sitting in the room with that person, you can listen to the music. You're not just listening to the words. And that is part of learning to be a therapist too, in that if I'm doing CBT, for example, which is what I would be doing, I have to know that the thought record's not automatic. How I will present it, what I would say about it, when I would do it, all of those things are really in my working memory so that I can listen to what the person is saying. And I can make adjustments in what I'm doing based on the fact that I have the 8-track therapy mind. And I can pay attention to what's happening in the room. And that's why this is such a difficult skill to learn, because there are all of these relational things that are happening that I've got to observe while I'm doing something and planning the next step. It's really fabulous. Because at the end of the day, it's interesting and fun, and it makes a difference.
But what's important is that we know our way around our toolbox so intimately that we can really be fully present in the room, because we're not constantly spending energy thinking about where do I go next, or what's the next question going to be. We can immerse ourselves into the experience with a patient. And I'll admit, I think that I have encounters that go both ways. I think I have encounters where I'm fully immersed with the patient. And I think I have some encounters, unfortunately, where because of what I bring into the room, usually, I don't find myself fully present in the room. And the time goes slower and my work is less meaningful and I'm more drained when I go home. And so I think, props to our listeners who are taking the time, probably on their time off, to learn about these things, because you're learning your way around your toolbox so that when you finally do find yourself in front of a patient as their doctor, you're really able to be fully present and help them.
I'll say one other thing about that, because it hearkened me to it before. That's why we don't stay up all night. Because number one, we sit still all day. And it's a lot easier to stay awake when you're moving. When I did CL, being up all night was when I was a pain in the neck, but I was just going from place to place and I could stay awake. If you're sitting across from someone 8 hours a day and you've stayed up all night, you'll know it. But the other part is it means that my toolbox is my responsibility. That is why I can stream shows not at midnight. I need to be rested. I need to have my own house clean. I need to put away the cares in my life and make certain that I'm available in a way that I might not be if I was changing tires. And so it is my responsibility to get sleep. It's my responsibility to have my life in order. And I think that's one of the most compelling reasons for psychiatrists to make sure that they get their own therapy.
Thank you for bringing that up. I totally agree. And I feel that in my soul. Dr. Sudak, do you think that we can teach people to be empathic, or do you think that people's ability to deliver empathy is based so much on kind of who they are to the point of residency and maybe how things were in their home, how things were in their social groups growing up, that empathy is something where you sort of have it or you don't?
That's a good question, and people have different answers to it. Mine is that those are much harder skills to teach. I can teach people very easily to do CBT, but they're much harder skills to teach. There are things that you can do though. So for example, there are skill sets that some people are better at than others. I happen to be a person who's not very visually oriented. I will be, I'll get on a train and I'll sit at the one seat on the train without a window because I just don't pay attention to that. And my husband will say, why didn't you sit there? But so the idea is, for me, nonverbals are something I know I need to pay attention to. And so one of the things I started doing was to watch television or movies without sound. Couldn't hear the words, could just watch the faces. And really start to hone in on, what does that look like? How are these people sitting across from one another? Because if you're a word-bound person, you can work on being less word-bound by sort of watching for that. And so there are things that we can do that help people to amp up those skills, but it's much more difficult, much more challenging. I think that it helps to be a person who asks yourself, why is this difficult for me? What's my contribution to the problems that I'm having with my patients? If things aren't proceeding the way that I expect, I need to think about, how do I conceptualize that? Pretty much that's the question I ask about everything that I do, which is how do I understand that this isn't working the way that it's supposed to? And is it because I don't understand this person correctly? I don't have the right conceptualization? Is it that I'm missing something? And if so, why am I missing that? And do I miss that in other patients too? And what's it about me that prevents me? Is it that, and so that questioning sort of attitude, otherwise known as, when my daughter was 13, we were walking down the street and we're having a conversation about something. And she looked at me and she said, don't you dare ask me why. It's just the way it is, because that's the thing. You're constantly, and it really helps to do that.
Talk about deliberate practice, watching the TV with no sound on. That's an amazing little anecdote. So one of my goals for this podcast is to give our listeners really concrete skills that they can take into the hospital with them to make a difference for their patients. So we're talking in really broad strokes about empathy and the nature of psychotherapy. What are some specific ways that we can demonstrate empathy to our patients?
Well, first of all, listen and reflect back. And reflection is not the same as paraphrasing. It's actually saying what the person is saying in shorter, more direct terms, and including something about feelings. Of course you're frustrated. Is that right? It makes sense you'd be so angry about this. So that you're really reflecting back and checking in, asking for feedback, right? sometimes you can actually try mind reading. Or if you see that the person is tearing up, you can say, I noticed that you're tearful. You must be really sad. That's much more validating than asking, are you sad? And if you get it wrong, the person will let you know. So you can try that out. You can think of the person's history, because if you know this human, you can even be more validating about this. So I happen to be a person who gets very easily embarrassed. And my husband and I were at an American Foundation for Suicide Prevention event, and I tripped on a piece of carpet and fell on my face in front of all these famous people. And Howard picked myself up, and Howard said to me, "Oh, honey, I know this must be so hard. I know you must be really embarrassed about this," because he knows that that's the case. And that was exactly right. So that's really validating. I know about you. It makes sense that you would feel like this because you've had this experience before. It makes sense that this would be hard for you because it was always hard when your mother behaved in this particular way. It makes sense that you would have this difficulty with your boss because you've had this rule that you have to do things perfectly. And so that's really validating as well. And if you're anxious about doing that, and certainly I would be anxious when I was a beginner, one of the things that I've taught residents for years to do is to start every phrase with like this, with "it seems to me that it might be like this," because that's just evidencing a hypothesis, and it's a lot less scary.
We actually talked about that in supervision a couple of weeks ago. I think that's a favorite phrase of most of our class.
Excellent.
So let me show some empathy here for our listeners. It makes sense that you're hearing Dr. Sudak, who is an internationally renowned expert on this, talk about this and thinking, wow, am I ever going to get there? You must be very anxious about starting residency and sitting in the room with people who are having such intense emotions. But let's just pull out one thing that Dr. Sudak said, which is it's okay to be wrong. It's okay to say something to a patient, to make an interpretation to a patient, to try mind reading for a patient and be wrong, because you are going to be a genuine human being. You are going to be treating that patient with unconditional positive regard. You are going to be modeling for the patient that a well-functioning, competent human being is often wrong because they are a human being. And what matters is how we deal with being wrong and how we adjust in session and also in the rest of life. Dr. Sudak, any cautionary notes on empathy, any common pitfalls that you see? You've taught a lot of residents. Anything you see that sort of makes you cringe a little bit or think, I think that's one that we really should stay away from?
Well, that's interesting. I think that it's not so much the cringing thing. I think that one of the things that people need to be armed with is how to navigate hopelessness. That hopelessness is a very difficult thing to navigate with patients. And at least where I work, we see many, many patients whose life circumstances are extraordinarily difficult. And holding hope when the patient cannot is often a very difficult thing to do. So I would say that one thing that's very helpful is doing exercises like thinking about, at the very start of therapy, what are all the things that are the strengths of this patient? What reasons does this person have to be hopeful? What reasons do you have to be hopeful for this patient? And being able to work to identify all of those, some of which include this person put their clothes on and came to see you. That this person had enough resilience and wherewithal to still come to treatment, even though things have been so hard. And so I think one aspect that is very difficult is that psychiatrists sit at the interface between social justice and medicine. And so we are often asked to help people with problems we can't fix, right? We're not banks. We're not the housing authority. We're not the child protective people. And frequently, the pain that people are coming in with, or many of the difficulties in their circumstances, are things we don't know how to fix and we aren't equipped to fix. And so it's figuring out how to help someone have a good life while they're navigating all of those challenges. How can they have a meaningful life in the face of sometimes terrible tragedy? And what bravery and personal wherewithal will it take for this person to face life as it is and make meaning and have a good life in circumstances, even in the face of such difficulties?
I was really interested in this idea of validating the invalid that you mentioned when we were setting up this episode, because I think oftentimes patients say things that we find it really difficult to agree with, or that sort of catch us off guard, and we want to build a therapeutic alliance, but there's something about what the patient is saying that maybe makes our stomach curdle, or that we don't feel we can get behind, and it can make it really difficult to build a relationship. How do we deal with it when a patient says something that we don't feel we can validate?
Well, so I think that the way it shows up for me a lot is because I see lots of folks who had suicide as part of their deal. And so many times it's the case that the person is just so beset with whatever it is that's going on that they don't see any other choices. And so I'm not going to say, oh yeah, that's a great idea that you tried to cut your wrists. But I might say that, it sounds like you just felt like you were at the end of your rope and you had nothing else that you could do that would calm you down. We still need to find something else that will calm this person down, but it recognizes that they really didn't see any other choices. I think that it's sometimes very difficult to validate or empathize with more difficult things. Like, for example, somebody who wants revenge against a person. That part of my stance about that is generally that it might be a pretty human response to being so angry with or wish ill of another person. And that it might be worth looking at the pros and cons of acting on that particular response. But that having that feeling is probably pretty human.
And is there something about that less adaptive behavior that we can empathize with? This sort of aggression that someone is feeling in another setting may be helpful toward them or their family in defending values that they consider to be sacred or something of that nature. So if a patient says something that we find to be less adaptive, are we able to search in there for the adaptive behavior and remind the patient that there's something about them and the way they are that is helpful, and that over time, if we're able to adjust the way we think and behave, we can kind of uncover more of that adaptive, helpful, pro-social behavior. So Dr. Sudak, I think another thing that can be really anxiety-provoking for new residents is just how intimate our work is, and how it can be really uncomfortable for us and our feelings, and how it changes us both in the moment and in the long term, and kind of navigating this really intimate sort of, I don't want to use the word odd, but it's such a special relationship between a therapist and their patient. You're getting to know someone in a way that nobody else knows them in, not even their spouse or their parents oftentimes. It's a really sacred job that we have, and it can be really difficult to navigate. So what do you have to say to new residents about kind of navigating those boundaries, navigating this really unique relationship, a relationship that we have never sometimes been in before, at least in the therapist role, navigating things like personal space, asking patients really intimate questions when we think that that's where the therapy is leading us, or kind of navigating boundary issues?
It is a weird relationship. And I actually think it's reasonable to think about how you're going to talk about the oddness of it with your patients and how you're going to navigate the oddness of it in the world. So, for example, patients will ask things like, well, can't we be friends? Or can I have a hug? Or here's a Christmas present. And we'll be set with, well, what do we do about this? Because in fact, it's not a friendship. And we have to explain to patients in a way, and I think sometimes people are so uncomfortable with the fact that they have to talk about this, that they wind up explaining it in a way that kind of is a little shaming. You shouldn't have asked me that, because we're uncomfortable talking about this. And we want everybody to know the rules before they come in. And instead, people don't know the rules, and they have different rules for other kinds of physicians that they see. So, for example, I think it helps to let people know that this relationship isn't like other relationships, and it has different rules to protect them. And those rules involve, number one, how much people get to know about us. Number two, what kind of contact we have with them once therapy is over. Number three, what the parameters are about physical contact or accepting presence. And that those rules are that way because the relationship itself is like a little bit of a laboratory in some therapies, so that the therapist, being somebody you don't know very well and is kind of a neutral stimulus, is important. And you've got to know which version of therapy you're doing for what the rules are, right? My kind of therapy, it's okay to tell people things that you would tell somebody on a bus, but in analytics therapy, it's certainly not. And it has to be what you would be comfortable telling. I happen to be a pretty private person, so that generally speaking, I might not tell people a lot on the bus, but there are other people who that would be different for. And so, you've got to always keep in mind that anything that you reveal about yourself has to be in the service of the patient, not just because you want to talk about your vacation. And so giving people the ground rules about why this is this way, because you're going to protect them, you're going to protect their confidentiality, you are going to protect the nature of this relationship so that it can be a one-way street. That's really what it's for. It's for their well-being, for their efforts in working to change. And you're not going to continue to have a relationship with the patient after therapy is over, because in fact, it can never be a two-way street after it's been a one-way street in a way that's fair, right? And so it's not about, and what I say to patients generally is that it makes total sense that you would want to know all these things. It makes total sense that you would want to talk about what was going on in my life, or it makes total sense that it would be important to you that you would want to give me presents at Christmas. And then you've got to decide patient by patient how that's all going to work. When are you going to take gifts versus not? What kind of gifts are you going to take, if you're taking any? And how are you going to navigate those sorts of issues? And I think it's very, very complicated. And that's one of the places where I think supervision is really helpful. Finding ways to say things to patients that aren't sort of judgmental in some way or sound that way because you're uncomfortable, right? Because it's hard to say to somebody, no, I can't accept this gift from you. It makes us uncomfortable. And often it comes off as, why are you bringing me that? So I think it's a good thing to keep that in mind and kind of think about what your stance is going to be about that. Because not everybody feels the same way about this. And in every circumstance with patients, there are certain things where boundaries are critical. And there are certain things to watch out for in terms of boundaries, in terms of, seeing people outside of sessions and navigating, making sure that you are doing things that are really in the service of the person that you're seeing. And I just think that's a complicated area.
Yeah, so certainly some hard and fast rules, boundary violations. You can never have an intimate romantic relationship with a patient. It doesn't matter how long ago they were your patient. You chose to go into psychiatry. This is a different specialty that is never allowed. That is a violation, as an example. And then there are things like boundary crossings, where sometimes in the interest of the therapeutic alliance, we may use a little bit of tasteful self-disclosure. And that is a boundary crossing, which could be appropriate as long as it is entirely in the best interest of the patient and not due to our own sort of personal motives, which, at times, especially if we're not really deliberate about it, can be difficult to tease out the difference. Dr. Sudak, I'm so honored that you carved out the time to talk with us and to share your expertise with all of our listeners. Do you have any final thoughts before we wrap things up?
I would just say what I usually say to people when they interview with us, which is, I'm really delighted that you're going to do this for your career. This is a phenomenal gift to do this work. And when the time comes that you begin to think about what you're going to be doing for a living, and you're looking for a job and you're anxious about things, make sure that you don't neglect figuring out what it is that you love about this work and asking for it. We are in short supply. We can negotiate for things that we often don't know that we can ask for. And so as you get closer to going out into practice, and everybody wants you to see 6 patients an hour because, time is short and that generates a lot of income. And so what you want to do is to say, no, that's just not the kind of job I want. I need to have X number of hours that I spend doing the thing that I want to be doing. And I'll do some of this other stuff because that's important and a good skill set for me. But I'm going to do it in such a way that when I go home at night, I sleep and I feel like I've got a rewarding job. You didn't spend your life learning to do this in order to be dictated to.
So you have spent a large part of your career in organized medicine, in educational leadership, and you have really defended the ethos of our career by making sure that we continue to teach psychotherapy, continue to build systems that allow us to practice psychotherapy. But what you're reminding us is really defending the ethos of our shared profession is incumbent upon all of us when we decide what our practice is going to look like. Are we going to allow ourselves to be wedged into very short appointment times where we don't feel like we're practicing a type of psychiatry that would be most helpful to our patients? Or are we going to be really fierce defenders of the quality of care that we're providing and make sure that we are using our gifts, skills, expertise to help people get better in the best way possible, and also to make sure our profession continues to be true to its values? Thank you so much for coming on. I've really enjoyed it.
Oh, me too. It was really my pleasure. Thanks for having me, Mark. Thank you for doing this. Take care. Have a good day. Bye.
Thanks for listening to this episode of Psychiatry Boot Camp. Please leave a rating and review. If you have questions or feedback for me, you can email me at psychiatrybootcamppodcast@gmail.com. The opinions shared in this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice.